Hey everyone, welcome to ABCs of Anesthesia. And I've got Erica again. Erica, how you doing?
Yeah, good. Thank you.
We're going to get started on another junior anesthesia Viva, and this is obviously in preparation for your RGA exam. And we're just going to drill some periop concepts
Yeah.
to pretty much assessments and what we do with some medications, and especially with the recent changes in specific diabetic medications as well. So, hey, why don't we actually tell us how's the preparation going for the exam?
Yeah, I actually was just Googling. So it's just under 12 weeks until the RGA exam. I feel like in classic me style, I have a pretty comprehensive study planner on a spreadsheet, and I've just been moving through that. So if all goes well, I should finish all my notes by the end of this week, and then also to head into revision phase. And then my study group, we're meeting once or twice a week to do practice Vivas at the moment. So that's been really good as well.
Amazing.
Yeah.
So it's so important to have that kind of framework, just to make sure you cover everything, because there's obviously so much to cover. So well done. Hey, so let's get started. I've just put in the chat the clinical situation. Imagine this is just a patient with lots of common comorbidities. 60-year-old male presents to pre-admission clinic for an elective total knee replacement, has past history of ischemic heart disease, CCF, COPD, diabetes, and rheumatoid arthritis. And the question is, what do you want to know on assessment of his comorbidities? Sorry, I've chucked in also his atrial fibrillation. Yeah. What do you want to know on assessment? There's an artificial kind of question, because we're obviously just going to try and go through all the assessment type stuff for each of them. Take a couple of minutes or whatever time you want to go through it.
All right. I think I'm good to go.
Hey, let's do this. Tell me about what you want to know about assessment of his comorbidities.
Yeah, so obviously this gentleman has quite a few comorbidities, and I think my starting point actually before all this would be getting a medication list, because I think that would help me to figure out to some extent the severity and stability of some of his diseases. But I'll come back to that. In terms of each comorbidity, I'd want to assess via history exam investigations, again, trying to assess the severity and stability. So with regard to the ischemic heart disease, I'd want to know a little bit about when and how that was diagnosed, whether he'd had a STEMI or non-STEMI or some kind of coronary event, or whether it was diagnosed incidentally without any event happening. I'd want to know a little bit about what management's been undertaken for that, and that will relate back to my investigations later. If he's had any stents put in, and if he's had coronary angio bypass surgery, and then what medications he's on, compliance with medications, and then if he's got any ongoing symptoms following treatment. So if he's got ongoing anginal symptoms, shortness of breath on exertion or at rest, any sort of, again, relating to CCF, paroxysmal nocturnal dyspnea, or what's the other one? PND, or I'll come back to it. So assessing essentially for complications, which leads me to the heart failure. And again, compliance to medications in this case, in particular if he's on dual antiplatelet medications. And then similarly, I think for all of them, the functional assessment is going to be really important. So what's his exercise tolerance? How is he functionally, including a full DASI, is probably going to be very helpful in this man to figure out whether he's going to be suitable for scenarioville. So I'm just going to say generally all of them, I want to know a functional assessment and how far he can walk and if he gets short of breath or chest pain. With regard to his CCF, again, I'd want to know a little bit about the history of that, if that was diagnosed at the same time as the ischemic heart disease, or if that's developed as a complication of the ischemic heart disease. I'd want to know a little bit about symptoms and exacerbations, whether he's ever needed to be hospitalized for an exacerbation of CCF, and then what medications he's on, including diuretic medications. And again, wanting to know about symptoms such as peripheral swelling, leg swelling, getting short of breath at rest or short of breath with exertion, whether he can lie flat and how many pillows he uses at night. And a little bit about, again, compliance with medications. And then with regard to the COPD, I want to know...
Let's keep on the ischemic. Is there any other investigations you want to look at?
Oh, yeah, sorry. I was going to do all my investigations at the end, but we can... Okay. We can talk about them now, I feel like, just because some of them overlap with each other.
Actually, trust your gut. Let's go with investigation at the end.
Yeah, okay. So with the COPD, again, wanting to know the cause of that. So if it's related to smoking or a non-smoking cause, because there can be genetic causes of COPD, when that was diagnosed, what treatment he's on, how his compliance is with his treatments. And again, knowing about exacerbation. So has he been hospitalized recently? Has he needed a course of antibiotics or steroids for his COPD? Is he still on steroids for his COPD? And again, the exercise tolerance and functional assessment will be really important relevant here. I'd also want to know if he's still smoking, if he's quit smoking, when he quit smoking, if that's relevant, and then calculating pack year history as well, if that's relevant to the COPD. With the diabetes, the history of that doesn't say actually whether it's type 1.
Actually, is there any other things for COPD that you want to ask about?
I think I'd want to also assess for any like symptoms suggestive of malignancy potentially. So if he's had like significant weight loss or functional decline in the last little while, I'd also want to know if he's on home oxygen, obviously.
Keep going.
Yeah. So diabetes, knowing whether it's type 1 or 2.
It's type 2.
Yeah, I assumed so. I just want to check. Again, knowing about medications, when it was diagnosed, how it was diagnosed, and then the stability I can assess through his BSL monitoring at home if he does that, as well as his HbA1c, and then severity looking at complications, including the macro and microvascular complications of diabetes, which he already has ischemic heart disease, so he's already got one at least. But then looking at renal function, if he's ever had a stroke, any peripheral vascular disease, any diabetic neuropathy that will potentially cause chronic pain, and any retinopathy, and then also asking about his sort of checkups regarding all of those, when he's seen a podiatrist, optometrist last, that kind of thing. So I think that's for the diabetes. Rheumatoid arthritis, again, just knowing a little bit about how and when that was diagnosed, what medications he's on. I'd want to know specifically what joints have been involved. So if it's just peripheral small joints, but in particular knowing if there's been any involvement of his neck or spine, and in particular atlanto-occipital joint involvement, I know can be quite significant for anaesthetics. I'd also want to know, again, if he's needed multiple courses of steroids for flares of rheumatoid arthritis, or if he's on chronic prednisolone for that, because that can affect your anaesthetic management. I'd want to know with regard to that if he's had any previous airway management since the diagnosis of RA, and if there's any known difficulties. I guess that actually relates to everything, but particularly for the RA. And then if there's any kind of immunosuppression relating to his medications that might affect his perioperative risk.
Any other complications that might be interesting for anaesthetists from rheumatoid arthritis? A bit rare.
Yeah, so you can have a lot of complications from the medications, including cytopenias and things like that, as well as you can get lung disease, or restrictive lung disease, either related to the arthritis or complications of the medications. I think you can also get cardiac involvement, including atherosclerosis and potentially myocarditis or conduction defects related to the rheumatoid arthritis. So it depends sort of how severe it is, but looking for other end organ effects. It can also affect the kidneys as well, again, medication or disease related.
Excellent. Keep going. Atrial fibrillation was one I added on there.
Yeah, so AF, again, when it was diagnosed, if it's paroxysmal or persistent, if he's anticoagulated, it looks like his TRADS-VAS will be a decent number, so he's probably on anticoagulation. If he's got any symptomatology with that, in terms of particularly if it's paroxysmal, if he's ever had a stroke as a complication of the AF, and then would obviously be wanting to, when I get to investigations, looking at an ECG and an echo for that as well.
Okay, good. Tell me about investigations now that we're there.
Yeah, actually, I probably should do exam first, because again, that's going to overlap. So in terms of my examination, I would obviously do a general inspection of this gentleman, getting an idea of his body habitus, how he looks at the end of the bed, look at the vital signs, including his oxygen saturations and rest rate, looking for any respiratory distress or evidence of shortness of breath. And then I'd want to do a cardiac, respiratory and sort of examination, in particular listening for any murmurs or evidence of fluid overload from the cardiac point of view, or any undiagnosed valvular lesions. With the respiratory exam, I'd want to obviously auscultate the lungs, listen for any complications related to COPD, including wheeze or sort of crackles in the airways. And then I'd want to do an airway assessment with particular attention to the neck extension, and any other sort of features of a potentially difficult airway. And then obviously probably briefly examine small joints and look for any sort of peripheral stigmata of these chronic diseases.
Yeah, excellent. Go for investigations.
Yeah, so investigations, things I would want in this gentleman would be a basic set of bloods, including an FBE, looking for pancytopenias, or HB if he's anemic. I'd also want UECs relating to his renal function because of the diabetes and a number of other conditions, as well as the medications he could be on. I'd want to look at a HbA1c to look at the control for his diabetes. Potentially we'll consider an ABG as well, given the COPD, just to get an idea of his oxygenation on room air. And then aside from bloods, I'd want to see a chest x-ray, given the COPD. I'd want to have a look at respiratory function tests if they've been done in the past to look at the significance of his obstructive plus minus restrictive lung defects and if there's any response to bronchodilators. I think an echo would be really valuable in this man, given the history of CCF, ischemic heart disease, and COPD. So really quantifying what his ventricular function is, but also looking if there's any evidence of right heart failure from the COPD or any evidence of pulmonary hypertension. And then assuming he's had some kind of intervention for his ischemic heart disease, I'd want to get a copy of the angiogram report, look at when that was done, what he had done, if he's had stents placed, what kind of stents they were, that kind of thing. I think that's everything. And then if it was at all relevant, potentially an x-ray of the C-spine as well, if I was worried about occipital instability. And obviously related to all of this, if he has any letters from specialists that manage these conditions, I'd want to be having a look at those as well.
Fantastic. And just imagine in the real exam, there'll be far less of these conditions.
Yeah.
So really good. Really good.
Sorry, I said ECG earlier, but definitely an ECG for the AF or a Holter monitor if he's had one done previously.
Absolutely. Let's give you a list of medications now. Feel free to just jot them down. He's on clopidogrel, an aspirin.
Mm-hmm.
He's on, let's say, metoprolol, an ACE inhibitor, and a statin.
Mm-hmm.
He is on Symbicort, and tiotropium, Aspiriva.
Mm-hmm.
He's also on prednisolone daily.
Yeah.
So he's also on rivaroxaban.
Mm-hmm.
And a flozin with metformin. And
In combination.
And he's on a GLP-1 agonist. Now, the realism of being on a GLP-1 and a flozin, I don't know, but we're going to chuck him on this as well. I've never told him, but for the purposes of this exam, we are putting on everything. Through that list of medications, before we get to the diabetic medications, let's go through all the other medications and tell me what you want to do with them and what does it depend on. So obviously, right now, I would generally give you a list of when his heart disease was, what happened, and all that. But let's be more variable and more vague with this, just so that you can outline what is important. So crack on.
So I guess things I'm considering is what kind of anaesthetic I'm going to undertake for this gentleman. He's having a total knee replacement, so spinal is an option, and that would be something I'd be considering because that may affect when I'd cease certain medications. In terms of ones I would want to continue, so I'd continue the aspirin, continue the metoprolol, including day of surgery. The ACE inhibitor, you can continue. Some people withhold it on the day of surgery for the risk of hypertension, but it's not a definite set in stone thing. Definitely continue the statin, the Symbicort, and the tiotropium because he needs all of those and he should have them on the day of surgery. Yep. With regard to the prednisolone, it would depend on the dose, but I'm probably going to lean on the side of giving him stress.
What is the dose that matters?
I don't actually know what dose matters. I think if it's chronic, I'd be stress dosing him on the day.
If it's 10, it used to be 10 milligrams, but now the guidelines has changed over the last quite a few years to 5 milligrams a day of prednisolone and whatever equivalent. So let's say 5 milligrams per day is the cutoff.
Yep.
Needing to do something with steroids of prednisolone or the equivalent or whatever else you might be on. What is the concern at that level, and what do you do about it?
So I guess the concern is that they're at risk of adrenal insufficiency, particularly with the stress related to surgery, and so that what you do with it is you give them stress dose steroids on the day of surgery. So I think often dexamethasone 8 milligrams is sufficient for that dose. But you could also consider hydrocortisone as well if you wanted to. But I think for this guy, 8 milligrams of dex would be appropriate. So I think that's all the ones I said I wanted to continue.
So that's right. So let's say simplistically, if someone's on 5 or greater, you give their normal dose and you give the 8 milligrams of dexamethasone for PONV or whatever, and that's everything for the day of surgery. How about afterwards, post-operatively? Do you know what the regime is?
No, this one I don't know whether you just continue the normal dose, like 5 milligrams daily, or whether he needs a sort of higher dose and then weaning back to 5.
Yeah, so you could do... So I've just got these guidelines, which are pretty recent, from 2020. I'll try to simplify this. So while they're nil by mouth, let's say, if they were nil by mouth, you could do 50 milligrams every 6 hours, so 4 times a day of hydrocortisone. It could be IV or IM. You could, if they're resuming enteral glucocorticoid, double the pre-surgical therapeutic dose for 48 hours of recovery uncomplicated. Otherwise, continue double oral dose for up to a week. So, resume the normal glucocorticoid at double the pre-surgical therapeutic dose, 48 hours. If recoveries come uncomplicated, otherwise, continue double that oral dose for up to a week. So if they're on 10, you'll be doing it 20. If they're on 5, you'll be doing 10. And that's for major surgery.
Okay.
I'd put this as some level of major surgery just because it's a decent bone operation.
Yeah.
Good. And what's the risk? Why are we doing that?
So the risk is adrenal insufficiency, which can lead to like an adrenal crisis if they're relying on the exogenous steroids for the production of those hormones.
Yeah, great. Excellent. Keep going with your other medications.
Yep. So I think I've covered all the ones I wanted to continue. And then we said we would leave the diabetic medications to later. So I'll just put them aside. With regard to the clopidogrel, so this one would depend a little bit on what kind of intervention he's had for his ischemic heart disease and when that was. So I might actually flip over to my AHA guidelines now and I can go through that.
So we're talking about clopidogrel cessation now, is that right?
Yeah.
Beautiful.
So it depends, broadly speaking, if he's had some kind of cardiac event and then had stenting in the last 30 days, that's very much a no-no, but it depends on what kind of stent he's had and what it was for. So generally speaking, if they've had just balloon angioplasty, you have to delay for at least 14 days. This is the 2024 AHA guidelines. If they've had a drug-eluting stent placed for an acute coronary syndrome, you're meant to wait 1 year. So they're meant to have 12 months of dual antiplatelet before you interrupt that. If they've had a drug-eluting stent placed for just coronary disease, then they say at least 6 months delay before you consider withholding one of the medications. And then for the bare metal stents, it's different. So it's 30 days of DAPT before you can consider withholding it. And then there's all these other variations depending on whether it's time urgent surgery or time sensitive surgery or not. I guess in this guy, knee replacement probably wouldn't be considered time sensitive. So you would just wait until it's appropriate to withhold the clopidogrel. And then in terms of withholding it preoperatively, I think it's 7 days for clopidogrel that you need to withhold it.
Beautiful. So just to summarize that, the AHA guidelines, 2024, they're the guidelines that everyone's going to use. And the great thing is they're free to access. So Google ACC AHA guidelines, and this one would be acute coronary syndromes, I believe, or even dual antiplatelet. What's the title?
Yeah, it's section 7.5. It's antiplatelet therapy and timing of non-cardiac surgery in patients with coronary artery disease.
Beautiful. And what's the full guideline title?
I think I just type in AHA 2024 guidelines or something and it comes up.
Yeah, sure. So the kind of too long didn't read of that is that there's all these different situations, but roughly in my mind I think 12 months, 6 months, and for certain urgencies 3 months maybe depending on risk. But at this stage, if the easy rule is you have to be 12 months post your drug-eluting stent. That's easy. Most stents these days are drug-eluting stents, so 12 months post that. And then if you need it earlier, most cardiologists will say, yep, look, 6 months is fine. But there's also subtlety to that. So I don't just say 6 months is fine. I call the cardiologist and go, hey, what do you reckon for this stent? Because stents can be, different, complicated. There may be certain bifurcations there. It's drug-eluting stents in certain patients may be high risk or low risk. And we don't know, as anaesthetists, we don't know the subtlety of that. So I'm always going to call the cardiology mate if I need to do it less than 12 months.
Yeah, there was also some mention in the guidelines of potentially using bridging IV antiplatelet therapy, which obviously is probably not something we're doing in Scenarioville, but something that could be considered if it's sort of time urgent surgery and they're under that window.
Yeah, excellent. Good. So that's clopidogrel. Keep going.
Yeah, and so the aspirin, given this guy has ischemic heart disease with a number of other risk factors, and I'm assuming he's had some intervention, I'd probably continue that perioperatively unless there was a significantly high bleeding risk.
Right. So
I don't know if sometimes you withhold on day of surgery, but...
Yeah, it probably doesn't matter. So primary prevention, they haven't had us in ischemic heart disease, just stop the aspirin. But if it is like this case for secondary prevention, absolutely, we generally stop it for 7 days. Cool. Keep going.
And then the last one I think I've got is the rivaroxaban here for the atrial fibrillation. So Again, it depends on what kind of anesthetic you're doing. But if I'm considering a spinal anesthetic, you'd want to withhold that 72 hours, so 3 days prior to the surgery. And similarly, I think if the surgery is high risk of bleeding, which I guess most orthopedic procedures have a reasonable risk, you also want to withhold that 72 hours prior. But I think if you're doing something like a gastroscopy or something that's less interventional, you actually can continue that. And you're not doing spinal, you can continue them perioperatively or withhold just day of surgery.
Yeah, and it gets complicated because
it also depends on their renal function for some of
beautiful.
them. Yeah.
So renal function is the other determinant. So let's say this person has normal renal function. You're right. So if we're doing a neuraxial technique, 72 hours of cessation, and if there wasn't a neuraxial technique, in this particular case, we could do 48 hours.
Yeah.
Beautiful.
I think that's all of the non-diabetic medications.
Nice. So just to recap, pretty much everything we continue in anesthesia, prednisolone, if they're 5 milligrams a day of prednisolone or greater, then we need to give them the stress dose. We talked about that already. And anticoagulants, obviously, they're a big deal. Antiplatelets like clopidogrel, we've got a whole thing in the guidelines. You can Google for that. And rivaroxaban and the NOACs, the newer oral anticoagulants, NOACs, apixaban, dabigatran, rivaroxaban. Absolutely, we're looking here at 72 hours cessation for neuraxial techniques and surgery, and 48 hours without neuraxial technique. So in this case, we'd do 72 hours. What makes him high risk? Like, what makes him potentially need bridging or not?
So the high risk factors depends on if they've got any kind of genetic thrombotic risk factors. And then again, regarding the stent, like what kind of stent they've had and when that was placed. And then the recency of any kind of thrombotic event. So it's something to do with like, I think stroke or, ACS within the last, I can't remember off the top of my head, I think it's 3 or 6 months. 6 months. It's 6 months. And then, if they've had a DVT or PE as well, that can be considered high risk. So there's a whole bunch of factors you look at for the patient. And then if they meet a certain number of criteria, you're potentially discussing with a hematologist about bridging them through the period whilst you're withholding their anticoagulation.
Back in the day, we used CHA2DS2-VASc for warfarin, but then that went out of favor when we were, even with CHA2DS2-VASc, high CHA2DS2-VASc scores, the hematologist considered that still not high risk. High risk was if they have an actual thrombotic event in the last 6 months, like you mentioned. If they have strokes or DVTP in the last 6 months or a clotting disorder, great. Now we're looking at high risk, whereas all the other things we wouldn't worry about bridging. And in this case with the rivaroxaban, absolutely don't need to bridge either. And that'll be a whole...
If you'd had a stroke or something in the last 6 months.
Yeah. And great. And then talk with the hematologist. Good. Let's get to the fun stuff. Flozin.
Yeah. So with the Flozins, the SGLT2 inhibitors, you want to withhold them 72 hours or 3 days prior to the surgery to avoid the risk of euglycemic ketoacidosis with these medications. Given he's on a combination, I'd probably give him a script for just metformin alone because he can continue the metformin up until the day of surgery and then withhold morning of. And then there's some ketone monitoring stuff with the Flozins. So do you want me to go through that now or come back?
Yeah, let's go. So let's say you get this guy on the day of surgery. He's appropriately ceased his Flozin the 2 full days and then on the morning of the third day, so 72 hours.
Yep.
What do you do?
So when they arrive, we want to check a BSL and ketones. Even if their sugar is normal, sometimes they can still have a ketosis because of that effect of the SGLT2 inhibitor. And then I was reading some guidelines just before, it said if they were sort of clinically well, appropriately had stopped their medication and the ketones were less than 1.7, you could proceed. But then it said if they were unwell and ketones were greater than 1, then you'd want to be getting a blood gas to assess the base excess and acid base status and then consider intervening from there. And
just a clarification, you may have missaid it, but if their ketones will be elevated from the normal fasting process, regardless of the fact that on the SGLT2 inhibitor. But yeah, if you were to go super conservative, so you're right with that number. The number I've got in my head is 1.6 because there's plenty of non-Flozin patients with ketones up to 1.6. So our guidelines kind of err on the side of saying, hey, it might be fine and it's just due to fasting. Let's say to be conservative for this exam, you say ketones greater than 1. Then you want it. What do you want to do now?
So then if that's the case, you want a blood gas. And then the guideline I was looking at, I actually think I closed it again. Essentially, it was an Australian guideline that was saying if the ketones were greater than 1 and they were unwell, then you get a blood gas, and if the base excess was less than -5, then you would consider that to be like the ketoacidosis, and you would commence IV rehydration with fluids plus minus an insulin dextrose infusion, and be monitoring your sugars and ketones hourly from there. So that was the guideline I was looking at. I think it was maybe 2023 or some Australian diabetes guideline.
That's reasonable. So my guideline would say the principles of what you're describing are absolutely right. So you get someone with ketosis greater than 1, we take a blood gas, a venous gas is fine, and they're saying base excess -5, we've got some acidosis present. In my one, I've got a pH of less than 7.3. And if that's the case, if it's above 7.3, we're happy. We can kind of proceed with the surgery and just monitor. If it's less than 7.3 or your base excess is less than -5, what do you do then?
So you want to commence rehydration with IV fluids, and then you want to commence an insulin dextrose infusion, which would be guided by your local hospital's protocols as to the rate. And then you want to be checking the sugar and the ketones every hour. And I guess at that point, you're also reconsidering if it's elective surgery, whether it's safe to proceed. I guess if it's emergency surgery, you're just going to manage them through that and continue monitoring. Right. And then there was also guidelines about when to recommence the SGLT2 inhibitor. So generally speaking, once their ketones have normalized, so less than 0.1, and they're eating and drinking normally, then they can recommence their medication post-operatively.
Less than 1, I believe.
Yeah.
Yeah, beautiful. So not 0.1, less than 1. And also just contact endo because we're trying to be super careful. But yeah, so that all those principles are right. You've got a well patient, ketones are elevated. This is a common situation. Just take a gas. If it's greater than 7.3, you're fine. Continue monitor. If it's less than 7.3, start them on hydration, get them insulin dextrose, call endo for whatever protocols you need to deal with. And I'll generally check it every 2 hours afterwards. Maybe if it's really severely off, then everyone I'll be totally reasonable. Mm-hmm. Good. Okay, I think that covers it. How
the GLP-1?
Also on a GLP-1. Let's say they're on one.
So they have new guidelines, or it's actually a consensus statement that was released this year about GLP-1 receptor agonists. And essentially, I'm just going to skip and read the recommendations. They say you should actually ask all patients if they're taking a GLP-1, I guess, given that sometimes it's non-diabetic patients taking it for weight loss. So I do tend to ask my patients this because I've been surprised a few times. And then it says that actually you shouldn't cease the GLP-1 peri-procedurally due to the risks of hyperglycemia or compromise to weight loss. So you should actually continue them through the perioperative period. And then the recommendation is to have an extended fast, so 24 hours of clear fluids, and then followed by a 6-hour standard fasting to reduce the risk of retained gastric contents.
What is that?
So the problem with them is it slows gastric emptying, so you have a higher risk of aspiration.
What does that practically mean? Because I think that when they were first written, it's kind of confusing to have a clear fluid diet for 24 hours and then a 6-hour fast. What does that mean?
I don't actually know. I was going to ask you if you'd clarify. Like in my head, clear fluids, 24 hours, that makes sense. But then the last 6 hours is like nothing at all. They can't even drink water.
No. So yeah, I'll clarify now. So,
or is it just 24 hours of clear fluids?
Imagine you have an operation at 8 a.m. It's 24-hour clear fluid fast and nothing from 6 a.m. So that's a 2-hour of fasting, because that's what the normal fast is. You can have clear fluids up to 2 hours before. So that's what they're saying.
Okay. Because I was confused by that. The way it's worded, it doesn't actually make that super clear.
Yeah, exactly. Yeah, absolutely. It's pretty confusing. But that's been clarified now through multiple communications with Anesthesia. So that's all good. And this will probably keep evolving over time just because it's such a new space and we don't have all the evidence. And we'll definitely find out what's going on in the next year. Maybe there'll be a new guideline.
Yeah, the only other things it says is just to consider other medications or diseases that would further worsen.
What is the clear fluid that you'll ask? What is a clear fluid, and what can they have for that 24 hours or 22 hours?
So it's any kind of fluid that you can essentially look through, is what I've been told, very simply. So things, water is fine, like clear apple juice without anything, any juice that's clear without pulp. You don't want pulp in it. I think technically Coke and things like that are not clear fluids because you can't see through them. So yeah, it's essentially just water and juice.
Yeah, good. And yeah, pulp fiber juice, absolutely. And so how about jelly? Is jelly a clear fluid?
No, because I think it's got particulate matter, so you can't have jelly.
Yeah, and there's all these protein drinks that are clear, but you definitely wouldn't give someone that. So, and jelly has gelatin. You just So clear fluid.
I have a question for you. Would you consider coconut water a clear fluid? Because this is a question I had with one of my patients once, and I was like, I don't know, because it's kind of clear, but it also kind of has particulate matter.
Yeah, I'd say on the harm level it probably is okay, but you know what? Don't even. I don't know. You need to know what's exactly in it, and I don't know what exactly is in it.
Yeah. What about Gatorade or sports drinks?
Gatorade and sports drinks. All right. Yeah. And the interesting thing is, so aspiration damage is from volume, particles, bacteria, and pH. So things like Coke and anything that's super acidic, suddenly you've got even more of a worry because of acid damage. So I would say things with a high acidity is something I'd want to avoid as well if I was a patient. So the guidelines don't really talk about clear fluids from the point of view of acidity as well. So sticking to apple juice and Gatorade and water is just a really sound strategy, I think.
Yeah. I think the other thing is they talk about potentially considering prokinetic agents or gastric ultrasound, but I think that would just depend on the situation.
Yeah, so let's say for your exam, then they're probably not going to go into that detail. But what do you know about prokinetic agents?
Yeah, so the one that they've recommended in the guidelines is IV erythromycin. And as we learned recently at one of our M&Ms, it's got to be over a couple of hours. I think it's like quite a slow infusion, and then you need to give it a couple of hours to actually have that effect of prokinesis. So it's essentially something you can consider if you're worried or there are residual gastric contents and you want to move them forward, but you have to proceed with the surgery.
Mm-hmm. It is a bit complex, and we routinely give it. So yeah, you have to wait 90 to 120 minutes after giving it, and it's a dose of 3 milligrams per kilogram up to a maximum of 250 milligrams. And so other prokinetics, you don't give Maxilon. That doesn't work with the same efficacy. It'd have to be erythromycin in this situation. Bedside gastric ultrasound, yep, that can be useful. And if you have the right expertise, you can have a gastroscopist or endoscopist put an ultra thin 5 millimeter gastroscope in a minimally sedated patient just to check the contents, and that might be a strategy so you don't defer patients unnecessarily. But yeah, good. So those are broad strokes, and that is all good. Excellent. Have we covered? I think
so. So we covered that's all of his medications.
Beautiful.
Although he wasn't on any rheumatoid arthritis meds, except for
prednisone. Yeah.
Yeah, but I think the DMARDs and everything have their own wonderful world of when to do it. But
that was really good. So I think we covered things really well. This was a really good example of you're just stepping through all the different things that I'd want to know. And I think just from feedback, the good thing as well, you already decided that you're going to do a history and then examination, then investigations. That was totally fine. That suited your strategy. And then also the fact that you gave lots of detail quickly. I feel like, that list of disease states that I gave you, I think every trainee, whether you're doing your RGA exam or even your final exam, you should really just have the ability to rote learn that at least, and just spit it out, because it's just it's the basics of severity and stability. So we got through a lot there, and you talked about functional assessment overall, which is great, and the DASI test, and I think that pretty much covers it. How do you know how to COPD severity? Do you know any grading systems for that?
The only thing that's coming to mind, which I don't think is a grading system, is the GOLDX, but I think that's the criteria for optimization. I think it depends on the respiratory function test, but I don't know off the top of my head.
Yeah, we'll use the GOLD classification. So if you mentioned that, then it's a combination of your I think your response to treatment as well as your respiratory function test. So that's good.
Okay, so the treatment actually then is guided by how severe your COPD is, because I know that you go up the pathway for increased therapy.
Good. Excellent. So thanks everyone. I think we've covered a lot of stuff there. So thanks everyone for watching, listening. And thanks Erica for being on again and sharing, just allowing yourself to be examined for other people's benefit in junior anesthesia Vivas.
Thank you.
Well, you have a good one, and we'll see you again next time. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.